Hi, everyone. Thanks for joining us tonight. I'm James Adams, the president of Gut Brain Axis Therapeutics. I'd like to welcome you to another in our special Gut Brain Axis webinar series. This is a presentation by two of the co-founders with me of Gut Brain Axis Therapeutics. They're going to talk about their amazing work as medical pioneers, their journey from fecal transplant to live microbiota products for treating many health disorders. Dr. Khoruts is a professor of medicine at University of Minnesota and the director of the university's Microbiota Therapeutics program. He's a widely published clinical gastroenterologist and cellular immunologist, and he's our chief medical officer. And Dr. Michael Sadowsky is a professor emeritus of microbiology, also at University of Minnesota. He's co-authored more than 450 publications. He's a fellow of the American Academy of Microbiology and the American Association for the Advancement of Science. He's our chief of operations and manufacturing for GBAT, and he's worked with Dr. Khoruts for many years. So I want to give many thanks to the 80 plus autism families that have invested in GBAT and helped support this presentation. And you can learn more about investing in GBAT at our website. But with that, I'm going to turn it over to Dr. Khoruts to take it away.
Thank you, Jim. If you wanted to see a video of me, which is not much to look at, Jim, you'll have to turn me on because I can't.
Yep, give me just a moment.
Okay.
I'm going to turn off my video and I'm going to go ahead and make you co-host so you can take it from there.
Okay. Well, I still can't, but I can share the
You're the
video.
host now. Go ahead.
Okay. All right. Okay. So, thank you, Jim, for the introduction. Um, this is a bit of a historical overview of how Mike and I have come together. And in fact, I think our partnership really symbolizes the strength of team science because we came from very different areas of expertise, and it is that combination that made this journey possible. So I'll take you back to, oh, I see. You can enable this pointer. So January of 2008. I had a clinic in general gastroenterology at the time, and this patient was brought in. Her name was Mary. She was a 61-year-old woman, and she was already at that point suffering with chronic diarrhea for about 8 months. She was quite miserable. She was basically living in a wheelchair, debilitated, having bowel movements every 15 minutes round the clock, day and night, lost about 60 pounds of weight. Story started some 8 months before she saw me with some antibiotic treatment for pneumonia. And through those 8 months, she was hospitalized multiple times for dehydration and received more antibiotics. So, what she had is a condition of recurrent C. difficile infection, which causes a diarrheal illness and is actually quite common. On the pictures here, you see a severe case of pseudomembranous colitis. This is characteristic of C. difficile infection. It damages the lining of the colon, and you see these explosions of pus, which actually are trying to maintain the gut barrier. It's a body's defense system, but it's also an indicator that the patient is very ill. On the right-hand side, the colon lining is normal and the lining is thin, so such that you can even see blood vessels. It's a common infection. It happens in about 500,000 cases in the US every year, and about 100,000, so about 20% of them, go on to develop recurrent infections. And it can be quite dangerous. and about 30,000 people per CDC die from this infection every year in the US alone. And the US is not the only country where this happens. It happens all over the Western world. So this is the basic overview of why this results. So your colon, that's the last part of the digestive system, contains microbes. These are normal, healthy microbes that are part of our body. And they, as we'll see later through this talk, perform numerous functions. But in this case, what they are able to do is to provide what's called colonization resistance. By having this dense microbial community in the colon of microbes that are adapted to our body, they're able to exclude invaders like C. diff. When Mary had pneumonia and got antibiotics, those antibiotics killed a number of microbes in her gut. And that made her vulnerable at the time to the invasion by C. diff, which is waiting for that opportunity. And C. diff likes to sit in the hospitals and wait for vulnerable patients in the form of spores. When those spores enter the colon, then they wake up. They wake up if the conditions are favorable. And that favorability is created by the antibiotics. Once they wake up, they make toxins. And those toxins then is what causes pseudomembranous colitis. This picture is another one of our patients later. And normally, we would treat that with antibiotics. So, and you're hoping to come back to the normal state. But you can see the paradox here. The whole problem started with antibiotics, and then we're treating it with more antibiotics. So while often that works, it's not surprising that some patients go on to develop a recurrent infection. And this happens because these antibiotics that we use to treat C. diff, the C. diff in this live form that's making toxins, are unable to kill off the spores of C. diff. Those are dormant and they're resistant to antibiotics. So if you can't get rid of the spores, and these antibiotics that you're using to treat C. diff actually kill more of your own normal microbes, you become even more vulnerable to another cycle of recurrence. And so the rule of thumb is, first time you get a C. diff infection, it's about 20% chance it's going to come back again. If you get it a second time, it goes up by another 20%, 40%, 60%, 80%, and then it doesn't go away. That was Mary. And so the solution, which was published about since 1950s, and it was occasionally used, it existed on the periphery of medicine. I remember it mentioned in medical school when I was in medical school in second year, and the entire class kind of giggled, is to really replenish, reconstitute, repair that antibiotic injury. And that is what we decided to do. Now, up to that point, um, this was something that occasionally was done. There were case reports, and people had an inkling of how it works, that it actually does repair the normal microbes, but nobody's ever shown that. And so, you can imagine that back in 2008, when I was going to bring this procedure into our modern environment, it took me about 7 months to actually come to that point, to clear all the regulatory checkpoints along the way, to convince the higher ups and management of the endoscopy center that this could be done, to reserve the suite for doing that. But I also wanted to actually see what happens. And in order to do that, I needed special expertise. And it just so happened that Minnesota is an agricultural state. And part of the science being done in Minnesota is soil science, which is another complex environment where microbes reside. And classical microbiologists, medical microbiologists couldn't help me. I had to reach to the Department of Soil Science to Dr. Sadowsky, who everybody pointed to is the expert to help me with this question. A very basic question. Do the donor microbes in graft, do they repair the patient's microbiome? Now, before that, this procedure is called fecal bacteriotherapy. As I mentioned, it was not necessarily a very original idea by itself. Uh, Even Chinese medicine described it some 1700 years ago as yellow soup. Back then, that was, of course, before antibiotics, but they had this special medicine, if you will, for people recovering from a diarrheal illness. And the yellow soup was made of human stool that was buried into the ground, stayed there for 20 years, and then they would take it out and dry it up and somehow um, powderize it and make it into a soup. Something similar was actually happening also in ancient Egypt, even before the Chinese. But since 1950s, here and there, in 1950s, it was described by Ben Eisman in Colorado, where they did some fecal enemas for people with pseudomembranous colitis, and that was before anybody knew anything about C. diff. Um, but actually, was able to contact Dr. Eisman. He was in his 90s at the time, and he told me that, yeah, we thought the antibiotics are killing normal bacteria, and we thought to put them back. And he also said, well, there was not much regulation at that time. We had a good idea, we just did it, and it worked. Since then, other people have occasionally put it through a nasogastric tube, mainly in Scandinavia. And then later it was described to be done by colonoscopy, which is a more direct route. And that's what I chose to do. And in fact, we did it for Mary. And at that point, she was already a year and a half into her suffering. And in the recovery suite, at the time of right after the procedure, as she was waking up, she said, I feel different. And she was cured. And Mike and I made medical history at the time. So this was we published the report about Mary in 2010. It was picked up by the New York Times. It was actually big news at the time because everybody was talking about microbiome. They were doing some early studies. It was a new frontier of science, but up to that point, nobody's demonstrated the power of microbiome. And what we were able to demonstrate with Mike that microbes from the donor, which was Mary's husband, made it into her colon and stayed there. That was engraftment. And that's based on Mary's case. The treatment was renamed into fecal microbiota transplant. And then Mike and I thought, okay, there's a lot more to be done here. Mary was one case. Gradually, I started getting more cases. And as I mentioned before, this is not an uncommon problem. And patients like that were seen by specialists in gastroenterology and infectious disease quite routinely. And so we thought this is a really important problem to take on. And we established a microbiota therapeutics program. This is an early photo of us back in 2013 at State Fair when we were trying to educate people about microbiome. That's me there on the left, a postdoc at the time, J.T. King, Mike Sadowsky in the middle, Matt Hamilton, a really important individual as well, a postdoc of ours who was instrumental in developing later procedures. And Alexa Weingarten was a graduate student at the time helping Matt. That was the entire program. And we also did some science together, trying to understand in more detail how does this actually work. In principle, it sounds kind of obvious. Yes, you normalize the microbial community, but what does that really mean? And so uh, this was Alexa's PhD thesis. What we were able to show is that at least one of the mechanisms is that the intestinal chemistry changes. The composition of bile acids changes such that it becomes favorable to C. difficile. So the C. difficile spores actually sense the change in the bile acid chemistry that's induced by antibiotics. And then they germinate, and that chemistry also promotes their growth and production of toxins. And when we introduce the normal microbes, they change that chemistry back. And even if some spores do make it into the intestine, they're not able to germinate and they're not able to progress to disease. Now, Mary's case was interesting in another way, in that um, her husband, who was her donor, happened to be a very healthy individual. They'd been married for 40 plus years. They shared their life together. I wasn't particularly worried that there was some infection that he was going to introduce. More than that, he was a very metabolically fit individual, really no health problems. I thought that's a pretty good donor. The problem was that in subsequent cases, when people would bring in their husband or their relative and sometimes a friend, these were not necessarily the healthiest people. I distinctly remember one patient brought in her husband, who was like 300 pounds and had a gastric bypass and had diabetes. And I was reading a lot about microbiome at the time and understanding that, as I mentioned, this is really an organ that's part of your body. And is there a chance we could be introducing diabetes with these microbes? That was an unknown. So I thought a really responsible thing to do, an important first step, was to standardize the donor. And so we built a donor program. Actually, I developed the criteria for how to select the donors, and we screen for all kinds of diseases. Basically, the donors have to be absolutely healthy, no prescription medications, no allergies, metabolically fit, uh, and there are logistic factors, as you'll see shortly, that they're able to actually poop on demand, and it works. It can work for manufacturing. So on bird's eye view, there's a lot of screening and recruitment that goes on. And another factor is that I'll mention is motivation of donors is also important. And out of those, we select the ones who are appropriate, and then by inclusion-exclusion criteria. But that's not the end. When material is made, it goes into quarantine where it's frozen, and only then, after as Mike will explain, the QA/QC department can release the material. During all this work, a couple of years, as we were setting this up, uh, we developed protocols of how to extract the microbes and cryopreserve them. And Mike will explain more about that. That was actually probably even bigger in terms of advancing this field forward into mainstream medicine than our splash in the news with engraftment of microbes. Well, this is just a busy slide that's showing all the work that goes into qualifying a donor. There's no need to read through all these details. On the left-hand side are all the screening procedures. On the right-hand side are all the testing that's done. Now, we've learned a great deal in running what now is the oldest donor program in the world of how often we see scary things come through absolutely healthy people with no symptoms. It actually turns out to be not that infrequent. We also realize that a lot of the patients that may be getting this material may be immunosuppressed or immunodeficient. So we really have to ensure that the material that is given is absolutely safe. Um, we also have to trust the donors, and that's the screening part. Um, that they haven't taken any medications, especially antibiotics. We know everything about their travel, about their habits, about their diet. They're essentially under a surveillance program. And why do they submit to this? Because they want to help people. I will. I really feel very strongly that this is an integral part of the of a legitimate donor program. The donor program is independent of any kind of profit motive in any company. It is a nonprofit. The individuals that participate in that want to help people. They have an altruistic motive, at least it has to be part of it. Um, and it has to be overseen. And it is, in our case, by an IRB, and we are audited twice a year by Clinical Translational Institute at the University of Minnesota. We've, of course, the donors have to donate in a supervised bathroom. They come on site. That's to maintain the chain of custody. So it's asking a lot. It's asking a lot to come for blood tests that have to be done at maximal intervals every 2 months. Could be shorter. There's COVID tests, a ton of questionnaires. So they do get some nominal reimbursement for the effort, but absolutely not to make any kind of meaningful income. So with that, I'll turn it over to Mike, and he'll tell me how to advance the slides.
Alex, you'll have to make me host so that I can have my video.
Okay. I would love to make you host if I knew how to operate things. Not here. Let's see. There's a chat message. It probably tells me how. No, not that. That's later. More.
Sorry, I don't know how to do it, but maybe Jim can help you.
Don't need a message. Sorry about that. So I'm looking under one participant. More, it says multiple participants can share simultaneously. Yes. Advanced share. I'm sorry, Mike.
No problem.
Under more. Jim has been operating this thing. Jim, are you there? Are you able to help us? I'm not making much progress, Mike.
Yeah.
Maybe you can just talk and I'll advance the slides and I can move the mouse.
Okay. So actually, can you go back to the previous slide?
Yep.
Please.
Try. You think it's doing it? Yeah, there we go.
So as the top of the slide says, microbiota transplant products are considered drugs by FDA, but they're also considered transplants. And more importantly, the products are biological agents or biologics. Next slide, please. The production of these materials, it became easy for us to realize early on that we needed both to have the ability to produce a standardized product and a product that was rigorously analyzed and released by, in this case, a quality control and development project that is provided to us, in this case, at our production facility. So I guess the important thing to say is don't do this at home. This is really a biological preparation that is produced under very rigid management conditions and controlled totally so that the product that we produced is compliant to all the FDA regulations, as well as a high quality product where we know exactly the number of microorganisms involved. So the facility that's required to do this is one that provides what's called good manufacturing processes, or a GMP environment. And we were very fortunate at the University of Minnesota to have such a facility, which is called the Molecular and Cellular Therapeutic Facility. And Alex and I started producing material in this facility roughly in 2010 because it provides all the core competencies that are required for this type of manufacturing. So it provides the critical control systems. It provides operation materials management, management of all the equipment that's in there, documentation of all the processes that occur through standard operating procedures, as well as what's called batch production records. And more importantly, it provides quality and compliance oversight to make sure that the material that we're producing is in fact of high quality and is safe for our patients. Next slide, please. The Microbiotics Therapeutic Program over the years have manufactured different products. And as Alex mentioned in the initial procedures, we used fresh liquid suspensions of, at this time, fecal microbes, which we call microbiota, which delivered to the patients via colonoscopy. And while the material worked very well, it had a few what we call ick factors, including the odor that's associated with it. But more importantly, it wasn't really available for mainstream medicine because you had to line up the donor, the recipient, the colonoscopy suite all at the same time, which made delivery of this material difficult. So we started to invoke upon a new method of producing frozen materials. So this is cryoprotected material. And in 2011, this material was shown to be just as good as the fresh material. So this was stored in a -80-degree freezer and delivered via colonoscopy whenever the physician needed to treat the patient. So that really was a game changer, as Alex mentioned. But having to do this technology in a colonoscopy suite presents some problems, including lack of reimbursement of the colonoscopy suite, difficulties of doing colonoscopy for the patients. So we decided to work on a new program to develop something that was more easily taken by our patients. And in 2015, actually, we developed an encapsulated preparation of more purified microbiota that were orally administered through special capsules that don't open up until they reach the colon. So one of the hazards of giving this material to an individual via the oral route is the pH of your stomach. So we had to avoid that by using these encapsulated materials. The materials were actually freeze-dried, so they were extremely stable. And that was another important aspect of our discovery and use in clinical programs as well as in clinical trials. Now, while that worked quite well, there are quite a number of individuals, including those in some autistic patients as well, which have inability to take either encapsulated materials or tablets. So we decided to embark on another developmental program which we're using now for both ASD patients as well as Hopkins patients, as well as other indications. And it's a freeze-dried, flowable, highly purified microbiological powder, which can be administered to the patient orally via a liquid carrier of choice, such as milk, juice, anything like that. And for those that have problems with those carriers, solid phase carriers, such as yogurt, could also be used. So this is a game changer for all those patients that have difficulty swallowing capsules or difficulty taking tablets. This freeze-dried powder, which is quite stable, can be easily shipped to pharmacies and patients' homes. They can mix it just before use, and it works quite well. Next slide, please, Alex. So the product manufacturing that we do requires FDA-approved protocols and standard operating procedures that I'm just outlining for you here because it involves quite a few steps. So Alex spent time talking about the donor program, and just because a donor donates some stool, it might not be adequate for our extraction of the microbes. The microbes are then, if that passes, extracted from the stool by sieving, that's essentially using a strainer, washing and concentrated. And then more importantly, we also at that point measure exactly how many cells that a patient will be given. So it's very similar to you taking a drug. When you take a drug, for example, Tylenol, they know exactly how much acetaminophen is in that tablet. And likewise, our product has an exact known number of cells, and our normal high dosage amount is about, and this is a big number, between 1 and 5 times 10 to the 11th bacteria. That is actually just a fraction of the number of microbes in your gut, which are 2 orders of magnitude greater than that. And those numbers are really hard to imagine for most people. Just remember, 1 million is 10 to the 6th, 1 billion is 10 to the 9th, 10 to the 12th is 1 trillion. So 10 to the 13th is 1,000 trillion. It's actually more microbes than there's stars in the night sky. Tremendous amount. Those microbes, once they're isolated and quantified, they're then subjected to freeze drying, ultimately packaged, and then they're held in a minus 80-degree freezer until they receive release from the quality assurance, quality control group that's separate from our group. And they ensure that we follow all the recommended operating procedures to produce a high quality and safe product. Next slide, please. So since 2010, Alex and I have been producing with our group materials at the University of Minnesota campus, molecular and cellular therapeutic facility. And that has allowed us to carry out quite a large number of projects related to treating patients, as well as clinical trials throughout the United States. However, as we move into later phase clinical trials, there was a requirement that we have our own facility to do so. So GBAT, in association with Alex and I and others in our group, have decided to open up a new microbiota production facility, which is being done at this Forefront Technology campus, about 22 minutes from the University of Minnesota. Next slide. So we were provided essentially an empty space, which we've now subdivided into 3 areas. A clean room that provides all the same qualities as is those at the MCT building at the campus. It actually restricts the number of particles in the air. It provides really high quality assurances of proper working of all the equipment, sterility requirements, air quality requirements. In addition to that space, where we do mostly the extraction and encapsulation or packaging of materials, we also have an associated research and development space, because as you can imagine, while we're quite pleased with where we've come over the years, we're not done yet. So we have a lot more research and development to do. And the office space next door will house our quality assurance and production staff. So we are really happy that this clean room now has been produced, and we officially take over occupancy of the space on April 1st and start beginning production of materials that will be used for our phase 3 clinical trials for ASD patients as well as Pitt-Hopkins patients. Next slide, please. So as Alex mentioned previously, not only were we very interested in showing that this technology worked, and it actually made people better and cured people of things like C. difficile disease, we were really interested in understanding how it works from a microbiological point of view. And this family tree here represents the 3 domains of life, which includes the bacteria, the archaea, which are very primitive bacteria, and the eukarya, which include us and animals and plants and fungi. A lot of these organisms are present in your gut, including bacteria, archaea, and fungi. Hopefully no plants and animals, but there will be a few animals, but not many. And we decided to focus our attention initially on the bacteria and simply ask, what does fecal microbiota transplantation result in the guts of the patients? Next slide, please. So this very busy slide, I'm actually going to simplify it for you, represents all the microorganisms that are present in the guts of our donors, some of our pre-FMT patients, and our post-FMT patients. The data was acquired by gene sequencing, and this represents the genomes or the microbiome present in the gut. So if you just look quickly at the donor, you can see that the donor is dominated mostly by bacteria that are represented by the green bars and the blue bars. Whereas the pre-FMT patients, those in the middle, their guts are dominated by the red bars. And these are called proteobacteria and include things like E. coli. Now, if you take the donor microbes and give it to the FMT patients, after a little while, you could see that their guts start to look like that of a donor. And that's why we refer to this as engraftment. The microbes have engrafted into the host. Next slide, please. And this is just another way of looking at that because there's a large amount of data, and this is just a summary of that data. And on the left-hand side is a little circle representing the microbiome, of this case, of our recipient, patient number 11. And in the center is a little donor dot, the blue dot, which represents all the bacteria in the microbiome of the donor, and the dots surrounding it represent what the recipient's microbiome looks like after receiving the donor microbiota. So it's much more characteristic of a donor than of the recipient. Next slide, please.
Yeah, I think I'm going to take over at this point and illustrate some of the very same points. What you're looking at here is a community of organisms. That's what microbiota really represents. It's an entire community where the microbes that are living in our intestines are working together. It's just like any complex human community. To make that work, you need all kinds of people. You need auto mechanics, and you need hairdressers, and you need some doctors. You even need some lawyers to make everything work. The green lines connecting the individual circles are representing cooperation, that these microbes are often found together. And so there's something about them being together that makes it more productive. As opposed to red lines, that seems opposite. They seem to be working against each other. You don't find them as often together. It's one or the other. Now, this is what a community looks like, microbial community looks like in a C. diff patient like Mary. Uh, Most of it is gone. A lot of the lines are red. It's like as if the remaining ones are still competing with each other and hate each other. It's not a healthy community at all. And this is what happens after the FMT. So this is the donor, healthy community. This is the devastated C. diff patient. And a week afterwards, you see basically the community is restored. You can imagine that to achieve this, you can't really do say a probiotic, which is contains one or a couple strains of microbes that don't even engraft. You really need to repair the entire community, and that's how we think these days in terms of communities rather than individual microbes. Um, Now, this is, I mean, C. diff was the foundational disease. It was a repair of a decimated microbiome, which resulted in this vulnerability to infection, a loss of particular function, colonization resistance against C. difficile bacteria. But there's a lot more to microbiome than colonization resistance against some infections. In fact, what we think today in the early 21st century is that an entire organ system was discovered in our lifetimes, which is this microbiome. This is a cartoonish representation. I'll just run through quickly the digestive tract. So we eat food, goes through the esophagus, then it goes into the stomach, which is this pouch that prepares the food for further digestion by making it in small particles. Then it goes into the small intestine. That's the longest part, and that's where digestion and absorption of nutrients takes place. About 90% of nutrition happens through the small intestine. And then about 10% still undigested residual elements go into the colon or large intestine. That's where most of these microbes live. Um, Now, there's microbes in small bowel too, but not nearly the same density. In the colon, these microbes finish the digestive process. And if you like zoom in here under this cartoonish microscope and really go under high power, you'll see that, yeah, they're sitting there at the tables and they're munching and they're digesting things like fiber. And as a result, they make certain chemicals, very short chain fatty acids, and a whole slew of different chemicals that are actually beneficial to the host. We've been together with these microbes for millions of years and have learned to live together. It is really a mutualist relationship. And so these chemicals then interact with the human body. And as you know, um, from other seminars, some of these chemicals are important for the nervous system. Some of them are important for the immune system. Some of them are important for energy metabolism. So really, what's happening in the gut is important for the entire body health. Um, and it's illustrated again here through interactions. What happens between the microbes, how they interact with each other and the host affects the nervous system, the immune system, the digestive system, and all these systems actually interact with each other as well. And that's why, as the next step in our program, we decided that we had this unique capacity to manufacture these microbiota-based products from healthy people, and we could explore how they can help patients with variety of different conditions. This is really a unique program in the United States, and different investigators from all over the country are contacting us to see if we can help them carry out different clinical trials. Now, here we're talking about gut-brain interactions. Um, so I should step back and again distinguish what we were trying to do here from the foundational disease which is the C. difficile infection. In that case, C. diff, the microbiome is decimated. It needs a repair. Everything else about the host is more or less normal. All these other conditions are much more complex. Their microbiomes, the indigenous microbes, are not decimated like they are in C. diff. They are intact, resilient microbial communities, but they are what's called dysbiotic. They contribute chemicals that are not necessarily healthy for the host and drive different problems. And so, what we're trying to do is restructure their microbiomes. That it requires much more involved and aggressive regimens. In C. diff, all you have to do is do one inoculum of microbes that we manufacture, and 90% of the time, with just one-time treatment, patients improve and the problem is solved. In these other conditions, well, the protocols are more involved. There's typically an antibiotic conditioning to kill off the microbes that may be harmful, followed by some cleansing, followed by repeated administrations of healthy microbes. In gut-brain interactions, as you know, here there's a major focus on ASD and Pitt-Hopkins syndrome. But there's other conditions. In advanced liver disease, for example, a major complication is what's called hepatic encephalopathy. That is a well-known condition that's associated with dysfunction of the liver and the gut microbes. And the treatment, the standard treatment for that is actually focused on the gut microbes. You can't quite repair the liver other than do a liver transplant. But you can help to remove the toxins from the body by helping the microbes do that. And that can be done either with certain antibiotics, but also by feeding them and substrates like lactulose. That's a standard treatment. And what we found recently completed a phase 2 trial showing that addition of healthy microbes to patients already on maximal therapy with lactulose and an antibiotic called rifaximin. Those are the only two standard medications for these patients. Administering the microbes to them provides further benefit. As you can imagine, there is a lot of interest in different digestive disorders. So we have several clinical trials in ulcerative colitis and Crohn's disease. Those are inflammatory bowel diseases that are affecting about 1% of the population together. For Crohn's disease, we're doing a multi-center trial. It's just starting, and it's running at Harvard, Indiana, Detroit, and New York, as well as University of Minnesota. Primary sclerosing cholangitis, another condition that's related to inflammatory bowel diseases. A very interesting application in helping also gut heal after a part of it is removed during surgery. There is intense interest in how the microbes calibrate immune responses. And so we have, I mean, as you can imagine, on a daily basis, what does the immune system see out of the microbial world? It is gut microbes. And so that's very important for immune responses of all kinds, including food allergies. So we have a collaboration with Boston Children's for peanut allergies. Similar idea is for cancer treatment. Probably the biggest, most important latest introduction in cancer therapies is immunotherapy, trying to engage your immune system to attack cancer. Well, it actually doesn't work very well if people are on antibiotics. So it turns out that having a healthy microbiome is important to really have your immune system being fit enough to fight cancer. And so we have a couple collaborations there. I also mentioned antibiotic resistance. This is a problem that is, you can liken it to a tsunami that's going through medicine probably in a decade or two. because antibiotics are used so much in medicine, you can imagine the bacteria are quite talented and they develop all kinds of antibiotic resistance. And there's a concern that if we just keep doing this the way we're going, we could be thrown in the dark ages in 10, 20 years, where most of the infections are going to be antibiotic resistant. C. diff is actually an example of those, but there's others. Here's one. You saw Mike, what Mike showed you, this big red bar that had microbes like E. coli. Well, those are clinically significant as well. And some of the C. diff patients actually do have complications with E. coli infections as well. This is another slide that Michael already showed, different domains of life. There's addition here is viruses. Whenever you have bacteria, there's also viruses that prey on bacteria that are called bacteriophage. And they're integral part of the microbiome as well in the gut. They're not the viruses that invade humans or human hosts. They are part of the predator-prey relationship in the bacterial world. This is some of the latest work that we've been doing. Again, demonstrating fairly similar ideas, but with a different level of sophistication. Here, what you're able to see is individual microbes as little flowers in the field, and they're associated with some bacteriophage, as well as pieces of DNA called plasmids. And that's what, on the left-hand side, you see a healthy microbiome. There's a big flower here in the middle that happens to be an innocuous organism that it has these accessory parts with plasmids that probably pose no harm. But then look at the patient with C. diff infection. Most of the flowers are gone. You have this massive thing in the middle and a couple of big cousins here. And those are part of that red bar that Mike showed earlier, except it's not just bacteria. They're studded with additional DNA and viruses, which some of which carry dangerous things like antibiotic resistance genes, as well as virulence factors. And when we just do this one inoculation of microbes, healthy microbes, you do see some recovery, although in at least half the patients, and including this illustration, the recovery is not complete in eliminating these more dangerous, potentially dangerous bacteria that are armed with virulence factors and antibiotic resistance genes. In about half, we'd see them completely disappear. So it probably does require a somewhat different regimen to really make the microbiome as healthy as that of the donor when we look at it this way. And so over the a little over a decade since we started, this is our group now. There's Mike and me. There's Amanda Cabage, who is seeing all the clinical operations, overseeing all the clinical operations, including the donor program in our program. There is Maradi and Mike Matson, Campbell, and somewhere here is Katie and Parker, and they're part of the manufacturing team. And I'll stop sharing at this point.
So with that, we'd like to go ahead and begin taking questions from the audience. Please put those questions into chat since we have a lot of people. And Dr. Khoruts and Dr. Sadowsky, if you can just go into chat and begin at the top and reading off any questions you want to answer. Read the question first, please, and then discuss it. Thank you.
Okay, I'll start with the first question that has nothing to do with my technical ineptness. At the present time, what are the effective alternatives to FTT since the wait for FTT will take precious time? Thank you. Well, it is MTT, and perhaps Jim can answer that one.
Well, you're the gastroenterologist, but
Okay.
certainly it depends very much on the condition that people have. Certainly, changing diet has a big effect for some people. Certainly, looking at if you're dealing with constipation, many laxatives. You can look at digestive enzymes may be lacking. You can look at possibly probiotics or prebiotics in some cases, but really, many of these are just
Yeah.
temporary treatments for the symptoms. And at least in autism, the core issue is changing these, I would call them bacterial infect or yeast infections, but just high overgrowth of harmful bacteria and yeast. But Dr. Khoruts, you've seen
Okay.
a
So,
couple hundred patients with C. diff and many more with other conditions.
well, the FDA does allow treatment using this methodology for treatment of C. difficile infections. There are two commercially FDA-approved products that are based on this idea. Physicians are also are able to administer it with material they manufacture under their own supervision, which means that really that doesn't happen that much. But in our a practice, of course, we do treat C. diff patients with our own preparations, and we do actually that free of charge. But that's restricted to Minnesota because that's my medical license. Um, the for other indications, it's the FDA does not allow this kind of treatment outside of clinical trials. So as Jim was alluding, if you're trying to make your microbiome healthier, um, diet maybe is probably an important component, but it really depends on having the right microbes there. So what we're hoping to do is get this treatment uh, through the FDA as soon as we can, get our trials done, which is where we need help of everybody. We need to partner with people who are willing to help us. The next question is, how can we test our 21-year-old autistic daughter to see if she could benefit from MTT and next steps? That would be you, Jim, again, because you
We have a
recently
lab that we've
performed the
created
test.
in the UK called Analudos. I'll put that information in the chat. And so we've developed a test that we made available about a month ago now, where you can test for a wide range of toxins from bacteria and yeast. And so it can tell you if they're present. We find they're present in about 80% of kids with autism and never present in healthy children. So I'll put that information in the chat.
Next question is, for efficacy's sake, is vancomycin pre-indicated always, or can there be exceptions? Well, we chose as part of MTT for autism, we chose vancomycin because there was prior data showing that vancomycin, at least temporarily, does improve in many patients the symptoms of autism. And their thinking is that vancomycin does target some of the harmful bacteria that are present that we need to remove. Vancomycin is also used for C. diff. It is a very potent antibiotic, and it does target the major groups of bacteria present in the gut. By itself, if you just stay on vancomycin, it's probably not a good idea because you really are going to destroy this microbiome organ without repair. And as you can see, certain monsters can arise as a result of that. Can there be other antibiotics? Perhaps, but those haven't been investigated. Can there be exceptions? Um, that's to be investigated. Like part of what vancomycin also does is create space for the new bacteria. It facilitates engraftment. So the dose, trying to overpower the indigenous bacteria that have been there for many years and adapted to that particular host and diet with newcomers can be very difficult. It probably requires much bigger doses, which are already substantial. Does bacteria-infused via colonoscopy reach the upper part of the intestine, the small intestine? Um, that's a good question. It's really hasn't really been addressed by investigations yet. It's something that I would really like to do. Part of understanding how any drug works is to understand its distribution. And the small intestine is one of the more untested territories. It's a frontier. It's hard to get to, whether you're going from above or below. Uh, my guess is that the microbes do move around, and there's probably some colonization there, but it really is begging for more investigations.
Alex,
Um,
could you turn could you unmute Mike? I think he wants to
oh,
add some
oh, oh,
comments in.
I thought he was unmuted, but let me.
You have to unmute him since you're the host.
Yeah. Back to my show participants. Okay, and
And
then
just click on him, unmute.
find Mike somewhere.
Alphabetical.
Oh, it is. Oh, I see. It's alphabetical, but it's first names. Um, Michael Sadowsky, yes. And
And while we're waiting on that, I'll just give a shout out to a very special autism mom, Ellen Bolte, who helped lead the first, inspired the first clinical trial of vancomycin, which 24, 25 years ago, which inspired me to focus on this work many years with my collaborators at ASU, Rosie Crouch Malnick Brown. And Dr. Rosie will be speaking in about a month, giving a similar webinar on this about the microbiome with our research scientist, Kem Nirpalkar. So stay tuned for next month for a great presentation from them. All right,
So
Mike.
thanks, Alex. Can you also turn on my video, please?
what I did is I made Jim host because for some reason my controls are not working, but I was able to make Jim host.
Okay. In either case, just back to the question Alex just addressed,
Mhm.
the microbiota in the small intestine is much different physiologically from that in the colon. So there's numerous differences between those types of microbes. As Alex said, it'd be really interested to study how MTT can alter both the small intestinal microbes as well as the large intestinal.
That's absolutely correct. And there's different availability of oxygen, which is part of it, and different motility, which all controls that. When we collect microbes from stool, pretty much all microbes come out, but they are dominated by colon microbes. It kind of relates to the next question as well. Is it in the intestine or colon that MTT is targeted? That's a good question as well, and uh, it's part of the mechanistic investigations that we still need to do. Most of the engraftment that we measure, all of it, is so far in the probably reflects what's happening in the colon, but it could very well be that some of the interesting biology is happening in the small intestine. Um, Next question is, autistic individuals tend to be picky eaters. How do they feed their microbiome community? Well, uh, certainly the nutrient flow is part of it. I believe, maybe Jim can comment as well, but there were recent uh, studies on this, how much of difference in the microbiome in autistic individuals versus those who are normotypical, um, is how much of those differences are driven by differences in diet. And they actually came out with a fairly small percentage is the estimate of about 2, maybe up to 5% difference. So um, that's the piece of data that we have from one sophisticated study, but I don't know how much of the picking it's a spectrum, right? So I don't know if taking the more severe cases, that contribution is much greater. The next question, I'm experiencing problems related to gas and bloating felt around my groin area for weeks that can also cause some intermittent pain, not stabbing pain felt in my testicles under my penis. I also have nausea mostly at nights. Would MTT help with the symptoms I'm having? Well, every case is unique, and without knowing a lot more detail about the case, it's hard to make any kind of diagnosis. But I can tell you, I get these emails like this routinely, at least every week. Used to be several a day, for people looking for an alternative like this. It kind of makes sense that this could be part of the solution. At this time, we really don't know. That requires different kind of trials, and this would not be one of the allowed indications in the current regulatory environment. Next question. Have you explored the effects of probiotic interventions such as Renadil or VSL number 3 in reducing levels of p-cresol sulfate or indoxyl sulfate, particularly in light of the pending availability of MTT? Additionally, are there any ongoing or upcoming clinical trials addressing this topic that have yet to be filled or released connected to ASD? Well, I have my, we showed you during the presentation that the microbial community that exists in the gut is very complex. There's hundreds of different bacteria alone, and then that's not even looking at the archaea and the fungi and the protists that are part of the community as well. So the notion that you can somehow repair it with a couple strains, such as contained in VSL number 3, even if they were to engraft, to have a major impact on metabolic output of microbiota is, to me, that seems like an extreme stretch.
Maybe, sorry,
Go
maybe
ahead,
I
Mike.
can add additionally, just to put this in some perspective, and there's some argument on the actual numbers, but it's thought that the adult human gut contains between 500 to 1,000 different species of microorganisms, varying from a few hundred to billions per individual species. So it shows you how complex it really is.
On the various pictorial slides, you compare donor to pre-FMT to post-FMT. Can you comment further on what conditions the patient had for treatment? What we showed in those slides are C. diff patients. We didn't show you any data on, let's say, ASD or other conditions. Those could be topics of future talks. There probably are topics of what Jim is planning, but this particular presentation was about the history of how this field developed, and C. diff was the foundational disease, and to this day, the most is known what happens in that condition. I don't know if Mike wanted to add anything.
No, thank you.
Okay.
One question I'd like to ask you, Alex, that you haven't quite addressed is, could you tell us how many people with C. diff that your program has helped, and how many adverse effects, serious adverse effects you've seen out of the many people you've treated or helped treat?
Right. Well, I've personally, as a physician, treated about 1,000 patients, a little over 1,000. It's been the incredibly rewarding journey for a physician to be able to do that and not argue with insurance companies. We've also collaborated with a nonprofit called Open Biome, which was distributing material that we were manufacturing for C. diff patients when we were allowed to do that by the FDA from 2022 to 2024. And through Open Biome, we treated about 8,000 people. It's an extremely safe treatment. And as you can imagine, patients with C. diff, they're not the healthiest. They received antibiotics because they had problems to start with. And so, nope, we didn't have any serious adverse events. It's you know, as you compare to any medication, it's as safe or safer than anything that has ever been out there because it's part of the natural body composition. His phase 2 of the trials for MTT already finished. When will phase 3 begin and seek to volunteer to participate? Jim, you probably want to take that one.
So we hope to be able to start a new phase 3 study for autism in about a year from now. We have to raise about $20 million to do that. So we're very grateful to the 80 families who've already raised $8 million for us. And now we're on to the next phase. So we hope to work very hard and invite a lot more people to invest in our company. There's a potential for very high financial reward. But most importantly, we think is the chance to help millions of people with autism, plus those over a dozen other conditions that Dr. Khoruts mentioned that they've been conducting clinical trials on and seeing a lot of success in those. So we hope in a year.
Next question is from Sebastian. Sebastian and I have been exchanging some emails. He's from Argentina and hoping to work with us as well for the many patients that they have in that part of the world. The question is, have you tried to perform FMT without the use of antibiotics previously? And have you used antibiotics and antifungal like Sporanox before FMT? So C. diff patients, of course, are naturally conditioned with antibiotics. As I mentioned, we do have vancomycin as part of the protocol for ASD, in part because its vancomycin by itself has been shown to be beneficial, at least temporarily. Overall, if you look at all the different protocols out there, they're published and ask a question, what variables favor engraftment of donor bacteria the most? The number one variable is whether the protocol includes an antibiotic step. Have we tried it without? Yes, we had a clinical trial for ulcerative colitis where we did not use antibiotics, and patients took capsules daily for 2 months. And we were able to get engraftment in some patients that was pretty decent. Other patients, maybe about a third, didn't engraft at all. As these microbes were just passing through because the indigenous microbial communities were completely resilient to that.
So if you remember, Alex called early on that the intestinal tract that's intact provides colonization resistance. And that's not only for pathogens, but also for other organisms that are coming in. And it's very difficult to budge the ones out of there that are existing without some antibiotic use.
Next question is, do you advise gluten-free, casein-free, soy-free diet? I'll just speak as a physician here, not necessarily in anything ASD. If there is a true allergy or sensitivity, then sure. And certainly people with very common problem of hypersensitivity called irritable bowel syndrome, if they go gluten-free, which is really not a gluten problem, it's more of the different polysaccharides that are contained in grains that contain gluten, they do feel better. But we always worry about restricting diet. You start restricting, taking away this, taking away that, taking away something else, and then what you see is loss of diversity. You're starving certain microbes out of existence, and that's been shown in animal models. So aside from that, that's one drawback. Another is if you start taking things away, the food industry will put something else instead of it. So it could be gluten-free, but then the substitute may contain extra sugars or something else that may not necessarily be healthy. So one has to be really careful with restrictive diets and really follow them if they're truly indicated. Have we invested the link to depression? There's a lot of interest in that microbiome, as the microbiome interacts with the nervous system, and there is ongoing research. It's not that our group has embarked on, um, but others are doing that. Jim has posted the link to the urine test. Can an autistic person diagnosed with mast cell activation also use the protocol? I see no reason why that could not be. I've personally actually been involved in a case of an individual with severe autism and pretty well documented mast cell activation syndrome. And he benefited, including not just for the autistic symptoms, but for some of the symptoms associated with mast cell activation. For example, his scratch test, which was 4+ positive, became negative. And we've seen some of these immune phenomena, improvements, which are of great interest to us as well, mechanistically. What can someone do since this treatment isn't available on demand yet? My family has autism along with various digestive and health issues. MTT is still a number of years away for those who can't get into a trial. Yes? Unfortunately, yes. Um, we've petitioned the FDA to allow us expanded access while we're doing these trials, and the FDA denied this request. They want to see full recruitment into the trials and trials getting going before they would open up anything else. Do the capsules in MTT reach the small intestine? We kind of talked about it. The capsules do reach the small intestine because you've taken them orally, and some of them do open up in the small intestine. The big question is whether they engraft, whether they stay in what microbes stay in the small intestine and what happens to the microbial community in the small intestine. That is a trial I'd really like to do, probably in a small number of individuals where we would sample that, but that's unknown. Next question is, can MTT be given to my son who is on the immune suppressant adalimumab, Humira, or would he need to stop it? There's no medical reason why he would need to stop it. We do have ongoing clinical trials, for example, in inflammatory bowel disease, and those patients are typically on medications like adalimumab or on adalimumab. And in fact, we think they work by different mechanisms in inflammatory bowel disease and may work together better. Whether the current trials or trials that are being planned may have that as an exclusion criteria, I don't recall. I don't know if you do, Jim.
Yeah, I'm not sure. In general, we're very cautious about anyone on immune suppressant. So for the moment, we're not allowing people on immune suppression into our studies.
Yeah, and then when clinical studies are done, we want to keep the cohort kind of uniform and not have extra variables. But I don't see that being a problem once the therapy is out. How can I be a donor? Well, thank you for that question. Um, the donors are truly our partners. Uh, they are not walking bioreactors of microbes. They're human beings, and we appreciate their contributions very much. But active donors, aside from all the testing that has to be done, they really participate intensely in the manufacturing. So you'd have to come um, to our bathroom in the research clinic. That's where the donations take place. And it's done at least 3 times a week when you are on call for manufacturing. So logistically, it may not work. And then the fecal material that's collected has to be delivered into the manufacturing suite within 2 hours. So we can't really accept material that's going out of state or we have to be flown in. Um, there's a kind of a thank you comment from a family whose son had MTT as a study participant, and they believe this treatment will do good things in the future. Um, the next question is about appendix. Have you given consideration to the possibility that appendix could be harboring pathogenic microbiota and post-MTT, the appendix serves to reseed the colon? There's an interesting theory that the appendix, part of the function of the appendix is to preserve the microbiota during a diarrheal illness. So when people have diarrhea, the appendix closes from all the flushing that goes through, and then it opens up after the diarrhea is over and reseeds the colon. And the concern would be, well, what if the microbiome is unhealthy to start with, and the appendix serves as to reseed? Um, Yeah, I'm not sure we're worried that much about it because what we're doing is we're introducing new microbes and then they'll have to fight it out with the residents anyway. And there are many mechanisms how that would be. I don't know if Mike wants to add to that.
No, I agree with Alex that the large numbers that we introduce, especially in those patients that are receiving antibiotics, seem to engraft quite well and they stay there a long time. So I don't think they're going to be reseeded with any bad ones that are in the intestine. Plus, they're subjected to antibiotics as well.
Yeah. Are children with autism malabsorbing essential nutrients because of their dysbiotic microbiome? My autistic grandson, despite a diet rich in meat and fruit, has low iron. Iron replacement has helped with sleep and restlessness. Um, Most of the microbes we're talking about are in the colon, uh, and those have nothing to do with iron absorption. Iron absorption takes place in the first portion of the small intestine next to the stomach. It's in the duodenum and initial part of the jejunum. Um, there could be other reasons why somebody would be iron deficient. One of the, when we see somebody of older age with iron deficiency, we worry about colon cancer because there could be bleeding. In women, menstruation causes a lot of iron loss through that. Although we still take it seriously whenever we see iron deficiency in an adult, that it could be GI bleeding. But in addition to loss of iron, there could be a problem with iron absorption, and that's a proximal or early part of the small intestine problem. So I don't think the microbiome has a big impact, particularly on iron deficiency. Most of the vitamins are also absorbed in the upper intestine. There are some vitamins that are actually made by the microbes, like folic acid, for example, and that could be a microbiome connection. Um, can my son with level 3 autism and a lot of GI issues get MTT in Minnesota? We live in California right now. Should we take prebiotics, probiotics, and postbiotics? What dose? And then there's other interest. Well, um, in Minnesota, we're still only restricted to doing this kind of treatment for patients with C. diff. So it doesn't really matter where you are. Um, at this time, really, the only way to get it is through clinical trials. And hopefully, we can get to a point where FDA will let us do expanded access for those who are not in trials. Um, how can my 5-year-old son sign up for the new study? I don't know, Dr. Adams. You have an
We aren't
answer for that?
allowed to do sign-up lists until the study's approved, and we won't go for that until we've raised the next 20 million or so. So hopefully in a year, we will then be able to have raise the money with help from thousands of autism families, and then go ahead and open the trials. And at that point, people can apply. But just by being on our email list, that's how we'll notify people about the study opening.
Okay. Do the bacteria embed themselves into the mucosal layers of the intestine? Would a bowel cleanse, such as that for colonoscopy or just a purgative, help remove some of these bacteria embedded in the epithelial layer? Either do it just to remove bacteria or before MTT. So the MTT protocol does use a purgative that is very similar to a colonoscopy prep. You're absolutely right that there are different ecological niches within the intestine. There's some microbes that feed on the nutrient flow, and they are called luminal bacteria. And there's some that are kind of grazing on the mucus on the surface of the intestine, and they are adherent to the mucosa. And it's similar to the previous questions about small intestine versus colon. This is kind of the distribution of different microbial communities. I consider that a very important question that has not yet been addressed. Certainly in autism studies and pretty much most other diseases. But those are separate compartments, and they may have different kinetics of engraftment. Does ozone treatments help with reducing the bad bacteria?
Maybe I can take that one.
You go ahead. You take that one.
Okay. So ozone treatment is typically used to reduce potentially pathogenic microorganisms from things like drinking water. And it's a strong oxidizing agent, and it's not specific. So it reduces all bacteria, similar to what Clorox would do. So we don't impose these types of treatments on human beings.
Yes, not for bactericidal effects.
No, because it will probably kill the
Yes.
patient as well.
Yeah. How can we petition the FDA for expanded access as their contact? I think that's Jim's question.
The FDA in general has been very supportive of what we're doing, but they do have certain standards, so we're not asking people to petition the FDA at the present time. We hope instead we will be able to get approval of this treatment as we complete these trials. So the FDA has high standards, and we hope to meet those.
Okay. Or keep going. There's some thank
I
yous, and
think we've almost reached the end, so
okay.
maybe
All
if
right,
you
there's
want to
only
take,
two left. There's only two left, so we might as well.
go ahead.
And I apologize for keeping myself in the dark, so I look like some mad scientist here in the basement, but I am in the basement. Wondering what you would think of off-label clinics for FM as they do for stem cell treatment. Imagine that would soon be a thing. Thank you. Um, well, first you have to get a label, get an off-label. So it would be illegal, and we don't want to do that. We really can't cut corners. We need to get this therapy all squared away, approved, and that's the best way to be available for most people, in my opinion. I don't know if Jim would want to say anything more about that. I would say that every formulation that uh, that is manufactured is considered to be its own drug by the FDA. So somebody can't really, let's say this does get FDA approved, this particular way of what we're doing, um, because it's classified as a drug rather than human cell tissue transplant. Somebody else can't really open up a parallel clinic with their own product because that hasn't gone through trials, and so that would be illegal. And I actually do agree. There's different ways of preparing microbes, of extracting them from stool. You have to be very careful. You do it under anaerobic conditions. So just blending something together is not really the same thing. And we're also doing work in parallel, trying to really figure out microbial communities that are most appropriate for autism. So there's going to be more to it than just the healthy donors that I presented. That's a foundation, and they absolutely have to be healthy, but there's likely to be more to it. Um, let's see. I'm gonna the same answer to the next question of do it yourself. It's not something we could recommend. Um, how's our product different from Voust? Okay, Voust is a different product. It's a spore formulation. So what they do is they take fecal microbiota, that is the extracted bacteria from stool, and then they incubate that with ethanol. What that does, it kills off at least two-thirds of the bacteria. The remaining one-third is stunned and it undergoes a stress-induced program to make spores. That is, bacteria die, but they leave some progeny behind. And Voust collects those spores, and that is their formulation. So it is certainly a much reduced composition that what we have, um, and probably it can't really do the same kind of repair. But if Voust wants to get into this and do trials, that's what they have to do. But that's not hasn't been their direction.
So with that, I'd like to thank very much our two speakers. It's just been such a pleasure and honor for me to work with them for the last dozen years. And please, everyone, thank them for the great work they've done and are continuing to do. And stay tuned for in about a month from now, we'll have one of our other team from GBAT, Dr. Rosie Krajmalnik-Brown, and a research scientist, Kemal Nurmulkar, who will talk a lot more about the microbiome in people with autism. So thank you all very much for attending. I hope you enjoyed this. We will send around a link to the recording in a few days after we just edit it lightly. But again, many thanks to our two speakers for the incredible pioneering work they've been doing.
Thank you for participating.
Thank you.